criteria that we just discussed for sacroiliitis, and what do we see? Sequential grades of increasing severity of disease. So in grade 1, what are we seeing? We are just seeing some sclerosis along the sacroiliac joint. However, the margins are preserved and the joint space is also preserved bilaterally. In this image, what are we seeing? We are seeing in the mid portion for a significant amount of length, there is reduced joint space. There is sclerosis and subchondral sclerosis both on the sacral as well as the iliac side, and some subchondral lucencies also. This is grade 2. On left side, what are we seeing? We can just trace the joint up till here, and then frankly the lower half joint we can't even trace. This is grade 3, where there is partial ankylosis and still subchondral sclerosis is seen. Here we are seeing bilateral grade 3, significant irregularity along the joint, subchondral sclerosis as well as patchy ankylosis, and grade 4 is frank ankylosis through and through. Now, New York criteria. When do we label by this classification system? When do we label it sacroiliitis based on New York criteria? So when there is grade 2 lesions present bilaterally, or when there is grade 3 or grade 4 lesions present even unilaterally. So that is a radiologic weightage in the New York criteria. So 1 radiologic criteria and 2 clinical criteria. So any 2 out of these 3. What are the 3? Low back pain and stiffness for at least 3 months duration that are improved by exercise and they are not improved by rest. Right? The second part is limitation of motion of lumbar spine in both sagittal and frontal pain. And the third criteria, the third clinical criteria is limitation of chest expansion relative to normal values for age and sex. So this radiologic and clinical combination defines the ankylosing spondylitis. So 1 radiologic and 2 clinical is needed for New York criteria. Now ASAS that we are going to discuss now, this is old definition where there was very precise definition of what is bone marrow edema, and approximately 2009 this was revised. The slices taken then were very thick. So even 1 slice to 2 slice made a significant amount of disease burden. So if we were seeing 2 locations and on 2 slices, that constituted to what is active inflammation, that is no longer done. So this is another image showing the New York criteria and grades. So grade 1, grade 2, that is subchondral sclerosis is increasing. Grade 3 here sclerosis is increasing and some partial ankylosis is there, and grade 4 is complete ankylosis, right? So ASAS, the much mentioned or assessment of spondyloarthritis international society. So what does this mention? This also takes into picture the MRI is only a part of the story. Still remember, this is a radiologic webinar, but we have to remember that for this disease, just radiologic presence doesn't make it ankylosing spondylitis or axial spondyloarthropathy. We need to have HLA-B27 presence. We need to have sacroiliitis on plain radiograph preferably. If not, then on MRI with the SPA feature. These are the SPA features that we'll be discussing. Age of onset has to be younger, right? It can be from actually 20 to 40. It's got to be less than 45. And back pain has to be chronic and for a period of approximately 3 months or longer. Now this chart just shows how to approach a patient using ASAS. So a patient comes with chronic low backache, just get the X-ray done. If it's positive, it's AS. very easy. If it's negative, then we have to see for other SPA features. So these were the other SPA features. They are the same in both the slides. So they include inflammatory back pain, arthritis at other places, enthesitis, uveitis, dactylitis, psoriasis, Crohn's disease, response to NSAID, family history, HLA-B27, and elevated CRP. This is very defined, very precise, and these are the only, these are the things that are repeatedly re-evaluated even in response to disease. Now, if the X-ray is negative, we take all these things into consideration. If there are more than 4 SPA features present, they directly make it a SPA case or spondyloarthropathy case. Now, the borderline cases. If there are 2 to 3 SPA features present, then the next thing that comes to saving us is HLA-B27. So if HLA-B27 is positive with 2 to 3 SPA features also, it is a SPA. If HLA-B27 is negative, then other diagnosis or peripheral peripheral arthropathies could be considered. Now, if there is nil or 1 SPA feature present, but with HLA-B27 positive, then get a MRI done. If the MRI is positive, that makes it a SPA. So don't be in a hurry to label everything ankylosing spondylitis or SPA just based on MR signal. See, X-rays hold more weightage and are coming initially in the flowchart than MRI. Now, if there is SPA feature negative, and then you directly consider other diagnosis. And if even 1 SPA feature was present and you got a MRI done, MRI was negative, again that makes it another diagnosis. Now here are some. Now we'll be seeing some cases. So coronal T1, we are seeing. What are we seeing? There is complete. This is significant sclerosis and loss of joint space or focal ankylosis on the right side. And on fat sat images, we are seeing surrounding bone marrow edema and a portion of ankylosis. On the left side, we are seeing what irregular joint space. The whole right left SI joint is irregular with subchondral bone marrow edema. This was old definition and it's now removed. Active sacroiliitis according to AS is if there is osteitis or bone marrow edema and on typical anatomical location. So structural lesions assessed on X-ray, osteitis consists of active inflammation, and if osteitis is present, it responds also better to treatment. This is just a 3D picture showing the distribution of mechanical load, how it is there along the SI joint. So what makes it highly suggestive on AS is, like we said, osteitis or bone marrow edema, preferably in the cartilaginous portion of the joint, sufficient amount of bone marrow edema, distribution, so that has to be not ventral, means dorsal aspect, and structural lesions must be considered. So they, all of them together, make it highly suggestive of SPA. Now, what we mentioned, imaging arm and clinical arm. Imaging arm is sacroiliitis on imaging plus 1 SPA feature. The features we have discussed. Clinical arm is HLA-B27 plus 2 SPA features. And back pain and age of onset less than 45, back pain more than 3 months. These are another 2 cornerstones that we should remember along the whole path of our disease assessment. So again, in these patients, imaging arm and serologic or clinical arm. So sacroiliitis on imaging, active inflammation on MRI is highly suggestive of sacroiliitis with 2 SPA features, and radiographic features of sacroiliitis according to New York criteria. So because obviously if it's present on X-ray, it's more severe form of the disease. And these are the, again, SPA features that we just mentioned. Now arthritis or enthesitis or dactylitis, right? So These are again the SPA features. If they are present, then that makes it more probable for being labeled. This chart that we were mentioning. So here we are seeing. Here what are we seeing? That there is a grade 2 and 3. 2 on right side and 3 on left side, and that is confirmed on MRI. So we are seeing surrounding bone marrow edema also. We are seeing on coronal T1 irregularity along the joint space with subchondral fatty deposition also. So all this makes this in presence of radiographic presence, means X-ray पे भी positive है, तो फिर ये this is highly likely to be a case of axial spondyloarthropathy. Now so these are 4 patients in a group of 2. So this is patient 1, patient 2, patient 3 and patient 4. In all of these we are having some form of signal abnormalities at both the sacroiliac joints. We'd not be launching poll, but I want you to consider and think what is there in patient 1, what is there in patient 2, patient 3 axial images, and patient 4 again coronal images, right? So coming one by one. In first, second and third patients, what are we seeing is bone marrow edema. So there is bilateral, means along the sacral as well as the iliac aspect. On first patient we are seeing bone marrow edema. In the second patient also we are seeing bone marrow edema on both the sides. So in the third patient, what are the other findings? We are seeing structural lesions, mean joint space narrowing and subchondral sclerosis in the second and the third patient. So how the diagnosis that was made was, this is osteitis condensensi ilii. We'll be discussing it, what it is. This is the case of axial SPA, where the structural lesions and the bone marrow edema was both present. Here, because there was intense and disproportionate inflammation and there was some enhancing component also, this was septic arthritis and this was also axial SPA. Even though this was actually more chronic. What are we seeing here? We can partly trace the SI joint. We can trace it till here. There is ankylosis. We can trace it till here then. So there's fatty metaplasia of the adjacent bone and ankylosis. That's why no bone marrow edema is seen on stir. So axial SPA के ये 2 cases है. Now again another case. So this was a patient who came back for a vacation, from a vacation, and had back pain, and on imaging on T1 of spine sagittal we were seeing this, and on stir coronal we saw some hyperintensity in the sacral aspect of it, right? So this patient was labeled as sacroiliitis on the left side, and on T1 again some fatty signal changes were seen, and on stir slowly the hyperintensity settled down, right? And it actually extended along. Initially it was only on the sacral aspect, but later it extended along the iliac aspect also. So this patient had initial picture this, was diagnosed as ankylosing spondylitis, and then was treated with TNF-I, and still there was some actually disease progression. This is more chronic form of the disease. What is happening? Actually, this patient got misdiagnosed. It was a healed fracture, and on follow-up imaging on CT, some sclerosis was seen, and so this was misdiagnosed as sacroiliitis, and that is what I have been emphasizing, that just the presence of signal abnormality doesn't make it sacroiliitis. It could be a post-traumatic thing also. So sufficient imaging and sufficient clinical history becomes of prime importance before labeling this disease, right? Because see, these are typically young patients, young males, and the disease can obviously not be 100% cured, but can be modified only if the right diagnosis is made. So actually, it's even if you take on the responsibility ethically, it's very important you are making difference to somebody's whole life spectrum and their quality of life. Right. So here on coronal T1, we are seeing a significant hypointense signal on T1 on the sacral aspect with corresponding bone marrow edema. That was initial sacroiliitis, and it was some fatty, patchy marrow conversion was also present in the subchondral location. So according to, again coming to ASAS protocol, the imaging protocol include T1 oblique coronal. So oblique makes the whole SI joint visible and more clear, and any abnormality we can pick up better. Stir oblique axial, stir oblique coronal, and an erosion specific sequence, preferably 3D sequence, so 3D vibe or T1 fat saturated. This is a repetition image. Now coming on to lesions that are that we encase in in positive cases of sacroiliitis. So the lesions can be divided into inflammatory lesions or structural lesions. Inflammatory lesions include bone marrow edema, synovitis, enthesitis or capsulitis. Structural lesions or permanent damage, these spectra include erosion, fatty metaplasia, backfill, and ankylosis. What this technically means that this is a point of no return. Here, inflammatory lesions can still return back to normal and can have a good prognosis. Structural lesions, once start to set in and have set in, have a limited prognostic, capability. So bone marrow edema. So this is to be labeled obviously on a fluid sensitive sequence, and this is seen in the cartilaginous portion of the disease in the subarticular region. Has to be basically significant. Just a small foci of hyperintensity, you can't label it as a sacroiliitis. And again, with the clinical picture, with the pain extent and with the duration of pain, you have to kind of correlate. And not restricted to ventral aspect of the joint, means it has to go to dorsal aspect also. Now, enthesitis. Enthesitis, what we said, where the ligaments directly attach to the bone. So here on coronal, along the iliac crest, we are seeing some hyperintensity. This is where the tendon attaches, and if the hyperintensity constitutes to enthesitis, right? Here again, so all along the superior aspect of iliac crest also is a common form, is a common this one of enthesitis position. Now capsulitis. So apart from the subchondral bone marrow edema and this focal ankylosis, again, what are we seeing? The superior most and the inferior most portion of it is capsule, right? We mentioned. And see, when normal, actually it's this normal black continuity is maintained. And if there is some thickening and hyperintensity here extending, if you could appreciate, that is capsulitis. Obviously, it is better appreciated on fluid sensitive sequence, yes, but best on post contrast sequence. Now coming on to synovitis. Similar, so synovium along the joint space, yes. T1 fat sat image is a good sequence to see these, but the best is IV gadolinium, and not only post contrast images, but actually theoretically the proper synovial thickening is to be seen on subtraction images, means post contrast minus T1. Now coming on to structural lesions. So we have just discussed inflammatory lesions, so the spectrum that is seen in sacroiliitis. The structural lesions, the spectrum that we see in sacroiliitis include erosion, fatty metaplasia, backfill, and ankylosis. Flowchart that we said in the initial slide, how the disease progresses. So along the antero-inferior aspect of the joint, that becomes more important to see. So erosion. So it can be full thickness or partial thickness, yes. And full thickness loss of dark appearance of either iliac or sacral cortical bone. So here the cortical bone, so not only is the joint space narrowing, but the cortical bone, that see, the medullary bone is grayish, the cortex appears pitch black, and here the interruption, the cortical bone also classically shows erosion, focal erosion, right? And there is significant subchondral edema also adjacent to that erosion. Again, here we are seeing full thickness loss, focal loss along the black contiguous line that we see in continuity in here on the left side. It can also be seen as change in the normal bright appearance of adjacent bone marrow on T1. So even on T1, adjacent marrow also appears. The normal bright or fat thing gets replaced by this sclerotic thing if there is classical erosion. Again, we see focal erosion. Now, fatty metaplasia. What happens is, as a result of inflammation or insult, so post-inflammatory, there is in the marrow deposition of fat, and that is a metaplasia. So that is esterification of the marrow, and it is best seen on T1 fat saturated images, preferably coronal. So here again we are seeing fatty metaplasia. So even after fat suppression on T1, we are seeing this hyperintensity. Again on stir also, on T1 and stir, we are seeing this hyperintensity bilaterally and more on sacral aspect as compared to on iliac aspect. More on sacral aspect as compared to on iliac aspect. So here, what do you compare it with? With the, even if fatty metaplasia is there, the central portion of the sacrum tends to be left back. So the hyperintensity develops in the subchondral location, maybe reaching up to these foraminal, planes. So if you compare it with the central portion of the sacrum, you will see hyperintensity along the subchondral location on both the sides in case of fatty metaplasia. Yeah, so compare the signal of the middle third with the peripheral two-third. Now, what is backfill? Backfill is basically a precursor of fusion, and what it is seen as, we just discussed erosion. Within that erosion, if you see centrally T1 hyperintensity, that is what is called as backfill, and it classically has a sclerotic border. So intra-articular T1 high signal filling erosion, and that has a sclerotic border. And on stir sequence, you can see adjacent bone marrow edema. However, this is black. So this is what is called as backfill. Again, here we are seeing central T1 hyperintensity. This is a more zoomed in image. Now, the last stage is fusion, where you frankly don't see a joint space anymore. So, bony bridges or confluent T1 hyperintense signal, and there's loss of joint space, and there's marrow continuity on the sacral as well as on the iliac aspect. That is what is the last stage, or fusion, or we say burnout of the disease. Classically, there is no bone marrow edema associated with this. So here again we are discussing one case. So suppose if it was a LS spine with SI joint, even on LS spine, what you have to remember is, apart from the degeneration, the inferior and superior portion, the what is known as shiny corner sign. So any hyperintensity classically here does show enthesitis. Apart from it, on T1 and T1 post-contrast images, what are we seeing? Partial ankylosis along the SI joint as well as fatty metaplasia. Yeah. And this is showing some amount of post-contrast enhancement also. So even though the disease is chronic, it does have some active component. So maybe clinically, patient can be helped. Now, this is mostly about sacroiliitis. And now coming back to why I was emphasizing about the history, because that history helps us differentiate from a spectrum of more common differentials, and they should not be missed. These important differentials include stress, postpartum, osteitis condensensi ileae, infection, and insufficiency fracture. So here, on a axial SI joint image, we are seeing a hyperintensity on the sacral aspect and then on the iliac aspect. This was again like that two clinical scenarios we were discussing. Was an old patient suddenly enthusiastic about exercise and now having some scattered regions of hyperintensity along the sacroiliac joint. So we did share a 3D model picture showing the normal load distribution on SI joint, and that is just how these stress related bone marrow edema can also present, suppose in unaccustomed athletes or in comparatively older people starting or taking up exercises. Now coming on to entity that we shortly mentioned, osteitis condensensi ileae. What is it? It's a postpartum condition. It's seen along iliac aspect. So because of the pressure of the growing fetus on the bilateral SI joint, there is sclerosis along the iliac aspect of bilateral SI joint. Classically, because of its chronic nature and slow growing nature, it's got no marrow edema till the time the patient comes to us generally. So you just have to see that, okay, see this black thing, this cortex along the iliac aspect, see along the ala it's thin, and then suddenly it's become irregular and thickened, but it's only on iliac aspect. There is no edema, and adjacent SI joint space is very smooth and contiguous. This makes it osteitis condensensi ileae. Obviously, you will have a history of postpartum status. Again, here we are seeing the same thing. So it's predominantly along the iliac aspect. You can sometimes do see some, maybe fatty metaplasia can be there on the sacrum also. One more important diagnostic clue is even though it's postpartum, but because of the chronic pressure changes, maybe osteitis pubis is also there, and in the pubic symphysis also you can see some hyperintensity and irregularity along the joint space. So postpartum, they usually low back pain starts during the pregnancy and resolves sometime after childbirth. 4% of the women have a postpartum pain that persists for more than 6 months after childbirth, and there are several factors that may include low back pain during postpartum period. That includes these, right? Even stress fractures can occur, and also some association with epidural anesthesia can be there. So this is just this was just a study that showed that in up to 50% of the patients having postpartum bone marrow edema, erosion and fatty bone marrow was rarely detected. Postpartum bone marrow edema is not distinguishing factor of SPA, right? So that now it can be infective also. So maybe you can see stigma, like this is a case of tubercular sacroiliitis, like it's mentioned. So maybe you can get a systemic stigmata of TB, and here along in the subcutaneous plane, a large collection pocket is seen, and on axial C, it's frankly extending into the left SI joint, and here extending into the subcutaneous plane and the gluteal region. So this is sacroiliitis, but infective and tubercular in nature. Now, sacral insufficiency, the named sign or the Honda sign that is seen on bone scan, is also seen in this sacral insufficiency fracture only. So how does it present on MRI? You can see marrow signal abnormality along the ala. most commonly along the ala of sacrum, and that's only on sacral side, not crossing the joint line or involving the iliac aspect of it. Some focal, something was seen, but predominantly you see it only along the sacral aspect of it. So while reporting sacroiliac joint, we should see the inflammatory changes we mentioned, the structural changes that we mentioned. Now, the likelihood, so the more history that you can get out of those SPA features being present or not, make it more or less likely, even in presence of MRI signal abnormality. As a radiologist, the most significant thing that you can do is, if the X-ray of SI joint is not done, get a proper SI joint X-ray done. Right, that might make a big impact on how the patient is treated further. And yes, very simple tip is also mostly proper SI joint X-ray. Suppose if the patient is very sick, do give a bowel preparation probably, because something very minor confusion like, is this a bowel shadow, is this sclerosis or not, they are avoidable factors. So if you are taking so much pain and making an attempt, make it good. And then we need to differentiate them from the differentials that we mentioned. So our presentation till here, we aim to make the diagnosis early so that the treatment can prevent the irreversible damage from happening. MRI is the investigation of choice. We have to report inflammatory changes, we have to report structural changes, and we have to be in communication with rheumatologist. That makes really life easier. Yeah. So now this is a case of early SPA. So this was a young man, inflammatory back pain and HLA-B27 positive. So what are we seeing? We are seeing on left side some sclerosis, right? Superiorly as well as inferiorly. On MRI, that was confirmed, and marrow, so sclerosis was also seen, and marrow edema was also seen. So structural changes were also there, and inflammatory changes were also there. So okay, the patient has become bad, but has not still gone into fusion, right? So whatever marrow signal, bone marrow edema is there, that component can still be helped with the drugs. So you should report both structural and inflammatory changes. Now another entity to remember, that you will get a point from history, is sports related changes. So it can be some low amount of scattered bone marrow edema in the SI joint, and they can be sometimes present in healthy individuals also. So that is why even if you see a mild speck and you overdiagnose it as SPA or ankylosing spondylitis, even that is not right. This is what this slide means, right? And it is commonly occurs in mostly posterior lower ilium, followed by anterior upper sacrum. There is obviously no ankylosis and rarely any erosion is there. So again, see, sports related studies are more done outside, and more extreme sports are played outside. So this paper just highlights that how recreational runners or sudden unaccustomed exercises, they are more prone to developing bone marrow edema. And then extreme sports people are also accustomed to developing bone marrow edema, and sometimes that can be reversible with proper conservative treatment. Now coming on to pediatric patients. In juvenile spondyloarthritis, this affects children less than 16 years. Juvenile SPA commonly presents with peripheral arthritis and enthesitis, but given increasing use of MR signal, the actual involvement of bone marrow edema seems to be more common than previously thought. So basically in children, this can be seen as a part of normal growth process also, and the assessment of sacroiliac joint is more complex, and see, several factors including if the patient is in the pediatric age group becomes more important. Also there can be unfused ossification centers also, and sometimes you need to confirm that on CT and correlate with the age. So there are several types of it. You can take a screenshot of this, and this paper elicits the same of the pattern of marrow signal abnormality in growing age group, and these are not disease; they are part of normal variant of anatomy. So does this paper, yeah. Now coming on to anatomical variants. Anatomical variants of SI joint include accessory SI joint, iliosacral complex, bipartite iliac bone plate, semicircular defects, crescent-like iliac bone plate, dysmorphic sacroiliac joint, and unfused nuclei in the sacral wing. So this is an image showing accessory sacroiliac joint. Classically, it's seen at the S2 foramina level, and here we are seeing this accessory, fusion of the sacroiliac joint. So this is accessory sacroiliac joint. There is no marrow abnormality or sclerosis corresponding to this, and it's an anatomical variant. Now, iliosacral complex. So what happens here is the ilium opposite is there that there is very marked prominence of the ilium opposite to the concave depression that is formed along the posterolateral aspect of the sacrum. So this is also superiorly, means along the first and sacral foraminal level, and the prevalence is approximately 2 or 4% in the population and more frequent in the women. So that's again a normal this LSVT or lumbosacral transitional vertebra, the Castelvilli classification. That's very that is a very common spotter for you, or it could be part of a long case also with coincidental finding. Here we are seeing transverse process on the left side being fused with sacral ala. Yeah, here you are seeing marrow contiguity. And here you're seeing on the right side also. This was on left side. This is the classification system. So transverse process hypoplastic. So there are 4 grades. 4th is mixed. 1, 2, 3 is classified into unilateral and bilateral ABC respectively. So if there's hypoplastic transverse vertebra, unilaterally or bilaterally makes it 1A, 1B. If there is pseudoarthrosis between the transverse process, unilaterally or bilaterally makes it 2A or 2B. This frank fusion on unilateral or bilateral, that makes it 3A or 3B. And a mixed spectrum includes 4. So these two are the recommended papers for normal anatomical variant along the sacroiliac joint. Few common artifacts that we encounter while reporting these cases. So coil or motion effects here, because it is obliquely placed joint. So from the body surface area, so part of the joint would be less depth at a lesser depth, and part of the joint will be at a more depth. So if the coil is not really if the coil is old or not that properly functioning, what we get is coil artifact, or if the patient obviously moves. How it can be corrected is phased array body coil and motion resisted T2 sequences can be used, and they can help, and can locate or not overdiagnose the bone marrow edema. Now, vascular partial volume artifact. So here it occurs at the junction of cartilaginous and fibrous portion of the joint most commonly. And how do you differentiate it? That you see these linear hyperintensities crossing the joint, nearly crossing the joint. So they are actually adjacent small vessels, and pulsation or partial volume of these give rise to these linear hyperintensities. So that is pretty much it about my lecture. Thank you.
Thank you, Bhanupriya, so much for such an amazing talk covering the entire spectrum. There are few questions I know. Do you want to take the questions, or do you want them to?
I can take. Okay, I'll try to take as much possible.
Okay, sure. So so the initial 2 questions are almost same. People are asking how to differentiate an infective from an inflammatory arthritis, predominantly when it's a unilateral involvement.
Okay, so infective, the clinical blood and the blood picture does come to your place, means the CBC or the WBC counts being raised, and so that is the most common this. And if you see a frank enhancing collection pocket adjacent to it, that makes it infective versus the normal sacroiliitis. If it's very mild, then probably the higher blood investigations like CRP or HLA-B27, if the rheumatologist considers, that could maybe rule out SPA, and then we can think maybe if it was very initial infection and not showing on CBC, maybe by then that can be ruled out.
Yeah, and how often do you see unilateral SI joint involvement in ankylosing spondylitis?
Generally it's bilateral. I'm not sure about the exact percentage wise, and since it can obviously be asymmetric, but only unilateral can be in very early disease, yes, but generally it's bilateral, especially by the time patient presents to us.
Okay. Then the criteria to call something as MRI positive.
So the structural and the inflammatory changes that we discussed, that the structural changes were bone marrow edema, were enthesitis, sclerosis, and the inflammatory changes were bone marrow edema. I'll just open that slide.
Yeah, just that slide probably.
So, is my screen visible?
Yes, yes, it is.
Okay. So, for MRI positivity, right, for sacroiliitis, the inflammatory changes include bone marrow edema or synovitis, enthesitis or capsulitis. The structural changes include erosion, fatty metaplasia, backfill or ankylosis, the spectrum of progression that we discussed later in the presentation.
Right. If I remember correctly, there is also criteria for bone marrow edema.
Yeah, it was. The initial one was on 2 sequence, this one.
Right, either on the same slice, 2 locations, or at least on 2 slices.
2 slices, yeah. This is the article that gives a better, precise definition. So basically, they shows that they just repeatedly mention that it should be highly suggestive, means along the subchondral location, they should be present in typical amount. Initially, in middle, there were people who saying grading of 1/8 on both the sides, making it a 16-point score. But then they just say if it's significant or suggestive bone marrow edema. So the anatomical location of it and the capsulitis enthesitis association with it.
Okay. And the next question says, what are the structures to be seen while assessing SI joints on MRI? Sounds like an odd question. I don't know what.
So the things to be seen while assessing SI joint again, and in the disease of sacroiliitis, like we mentioned, is this. Again, this is...
probably trying to ask that again. What is the difference between syndesmophytes and bridging osteophytes?
That's generally seen in spine, and bridging osteophyte would be in osteoarthritic changes. You would see subchondral sclerosis along the weight-bearing portion of the joint associated, right? So that differentiates it.
Right. Then there is another question, which is actually an interesting one. Is it necessary to repeat MRI imaging if we didn't find any abnormality but clinically significant symptoms?
Yeah, so see, the disease may progress, no? Disease may progress. So if this, it depends on how much was the likelihood and what was the disease labeled to the patient. If it was an axial spondyloarthropathy case or a non-radiographic case, and even negative on MRI, then after a significant amount of, I mean, maybe yearly interval, I'm not sure about the exact interval and the diagnostic criteria of the follow-up range on time. But yes, if the symptoms are increasing, very well, there are n number of cases that were initially not positive and did become positive. So yes, it has to be if the patient clinically deteriorates. And all the other, see CRP, this one level also, CRP is not only positive or negative. Suppose if CRP value is increasing sequentially, right, there was a family history of psoriasis, then all these things do favor and make it that we should repeat MRI.
Yes, completely agreed. And I think the interval would be decided by clinicians based on symptoms, probably. So the next question is, why is fatty metaplasia bright on stir images?
Because this is not normal, fat that gets suppressed. I think I'll read up more and maybe answer later. But I'm not sure about the exact physiology. Probably the intracellular, extracellular fat concept comes into picture, if I'm not wrong.
Okay, I'm not sure that it should be bright. Then is enthesitis versus capsulitis on gadolinium images?
Capsule, by the virtue of its location, is the most superior and the most inferior aspect of the joint. So this is where the capsulitis will be. Enthesitis will be where the ligamentous attachment is there, like along the iliac crest. So the anatomy makes it different. It will still be enhancing soft tissue thickening only, but if it's present at the superior inferior most portion on coronal images, that's capsulitis. If it's at the ligamentous attachment site, suppose at the ischial tuberosity or along the iliac crest, that makes it this one. Capsulitis versus enthesitis. No, enthesitis, yeah.
Any ligament or tendon attachment.
Yeah.
Then the next question is, in normal spine, we also see shiny corner sign. What is the importance of that?
Probably you should, that should be reported, and while taking history, rest of the SPA features should be evaluated for it. Could be an early disease marker or could be not related. Both are possible. Not always shiny corner sign leads to SPA.
Okay, then the next question is, if osteitis condensans ili is a chronic subacute disease, why does it present with pain and what is the cause of pain?
It not always presents with pain, first of all. It can be an incidental finding in most cases. Maybe you can see it more commonly on CT abdomen than on MRI. You'll appreciate it more when it's very sharply only along the iliac aspect and the patient came for something totally different pathology. So generally it's not, maybe because of some significant sclerosis and some disease, case specific thing. Sometimes primarily it can cause pain, generally doesn't cause pain on chronic because it's a chronic condition. It's a chronic, the pain was there and now it's being picked up. Now there is no marrow edema also. Generally it's chronic.
Actually, we see a lot of osteitis condensans xyla in our practice, and it is quite often associated with edema also. So it presents acutely. It may present with symptoms. So
Okay.
So the next question again is what we discussed.
So, Dr. Geeta, why would that? Could you answer the question? I'm sorry.
So it is something like, as we have discussed already, it is usually which is seen more commonly in females postpartumly when you start to see. So females postpartum is one clue. You see sclerosis, but now there is an acute phase or an active component of the disease as well. So then when it is present, then you see edema. And in our practice, and there are a lot of papers also which suggest you see the sclerosis on sacral side as well, along with edema on the sacral side as well. So edema is not something which rules out osteitis condensans ili. It is something which you need to see sclerosis along with edema, the typical sclerosis along with edema. Then that's a clue that this is like a osteitis condensans ili rather than being sacroiliitis. But to be very true to you guys, we have lots of situations where we are stuck and we are not sure which category to put it into only on MRI, because you cannot see erosions that well, which is a good clue that you are dealing with chronic sacroiliitis.
Yeah, that's true. And then that itself, these two findings being coexistently present, do confuse us with sacroiliitis also. So maybe the rest of the SPA features, that's why they are so important. That what are the blood pictures, how's the clinical pain, is it more than 3 months, the age more than 45, the rest of the seropositive status. So I think that
so the entire picture definitely, and a word with the clinician does help. Then I'm just checking if we have any more questions, because rest all talk about the same questions. Is there any significance of just stir hyperintensity in SI joint? I again doubt what does that mean.
No, it could be artifactual. That's why those artifacts were also mentioned. So very less likely that there is no signal abnormality. Otherwise, an only stir hyperintensity is there. And if at all, then yes, it needs to be clinically followed up and correlated also, because that simply only stir hyperintensity doesn't make it sacroiliitis for sure.
Yes. And I think the last question, which I can see, which looks different, is should we use active on chronic ileitis on reporting?
Yes, like we were seeing, if we are seeing both structural and inflammatory changes, we are seeing erosions, and then we are seeing marrow edema or synovitis, enthesitis also, we have to mention active on chronic. Yes, we do. Yeah, completely agree. I think that kind of sums up the questions. Thank you, Bhanu, for being so patient. There are like tons of questions which no problem. Thank you so much, Angita, for the valuable input. Yeah, I was underread on those conditions, so thank you. No, actually, I was also surprised, but we recently started working, not recently, like now for 2 years, we're working with the rheumat team. So we realized that OCI is very common, which we were not thinking that it is. So it's always, I think, everybody just learns from their practice. Thank you so much. No, yeah, thank